We're fortunate enough to have Dr. Ciochetty here with us. Ciochetty works in anesthesiology and management. He's running our pain management clinic, kind enough for us to keep that going. Thank you very much. Our people and our both faculty as well as us appreciate you doing that. He's here to talk about CMS 506, which will be how CMS needs to look at us in the future with prescribing controlled substances. I don't believe you have any disclosures, do you, Dr. No, well, we don't, then I'll just, are you ready to go?
Mm-hmm.
Thank you, okay. No, I'll turn it over to you. Thank you for
Okay.
coming up.
Very good. First, a little bit of housekeeping. I'm pretty sure restrooms are out and to my left. And one of the tenets of the CME programs here at TJ is that the TJ health system does not tolerate dehydration or hypoglycemia. So anytime that you feel the need, and you go ahead and take advantage of the fantastic catering that we have here. My name is Dave Ciochetty. I'm an assistant professor at the University of Kentucky. And I have had the great privilege of being cornered by Dr. Lessenberry about 10, 11 months ago, telling me that Dr. Potter was leaving the pain clinic and they had not recruited a full-time person here. And I told him that I could not give up my teaching at the UK branch campus there in Bowling Green, because I not only teach medical students but also the residents there as well. And so it was a fantastic reward to turn over the pain clinic over to Dr. Joshua Rock, who had just who has now finished his fellowship in pain medicine there at the University of Kentucky, and is staffing that full time. Okay, so let's go ahead and dive into the CMS 506. CMS, of course, means the Center for Medicare and Medicaid Services, this metric will go into effect October 1st of this year. The first year is going to be for analysis, to go ahead and track and look at all the percentages and see if they improve, not improve. But eventually, as the usual behavior from CMS evolves, they will go ahead and unfortunately start, as they love to do, tie any type of reimbursement to our results, not only of the hospitals, but the health systems as well as drilling it down to individual providers. So on a preemptive basis, TJ Health System has asked me to go ahead and illuminate what the CMS 506 means and its implications. I'm going to preface this by saying, please don't shoot the messenger. Okay, so these learning objectives, you can go ahead and read them on your own. As previously stated, I have no funding relationships to disclose, and I will not discuss any off-label usage. This CME event does count for 1 hour toward HB-1. So this is what CMS 506 is, and in a nutshell, it means that they will be looking at patients 18 years and older who, upon discharge, will be prescribed 2 or more opioids, and it does not differentiate into short-acting and long-acting, or any type of opioid, an opioid being described as a Schedule 2 or Schedule 3, not the Schedule 4, as well as any of the Schedule 4 benzodiazepines. Okay, so this leaves out tramadol. Now, the exclusions obviously are anybody less than 18 years old. Anybody with an active cancer diagnosis, and anybody undergoing palliative care. That's important because, believe it or not, CMS has learned something. When Kentucky enacted HB-1, not only the hospice centers, the oncologists and hospitals were in violation right out of the gate because there were no carve-outs for palliative care to our patients. Here, CMS has carved that out, so that will not be looked at. So, why is CMS creating this metric? Well, let's look at the nationwide deaths, and this is through 2019. My thanks to Brett Guthrie, who helped me get the CDC database research. So these are, okay, in this graph, it shows any type of opioid in the top red line. The next line is any opioid without benzodiazepines, and the bottom line is any opioid with benzodiazepines. And you can see that is ever increasing. Just like you know that CDC just released last year, for 2020, they released last month, the 2020 numbers, and they have skyrocketed. People blame that on, and for lack of a better term, COVID anxiety. I'm sure there's going to be another CME, so that we can discuss that. So these are the national drug overdose deaths by opioids, along with benzodiazepine involvement. Let's look at this slide, which shows all benzodiazepines. And again, these are nationwide numbers. So you see that in 2017 it peaked, started coming down, and the 2020 numbers, which was just released, is higher than 2017. So it was a large peak, and we expect 2021, the preliminary numbers are even higher than that. And these are national drug overdose deaths. So let's go ahead and make it a little bit more personal. Let's make it just of Kentucky. This report generated on behalf of the Kentucky Department of Public Health, and I was able to get it through the University of Kentucky, shows numbers through 2020, and it shows an increase, like I said, from 2019 into 2020. And so let's break this down. And this is by all drugs, and then carving out opioids. So you see that the opioids definitely is the majority. They'll be covered in a future CME. And then we break it down by gender. You see that there's a much larger increase in male overdoses than female overdoses. And however, by percentage, by percentage is still male. Here it is, according to what they have defined as by race. Again, a much larger increase from 2019 to 2020. Here it is, civilian versus veteran. There was a comment made that a lot of the increase in overdose deaths were due to so many retired military as well as active military, seeing that we have both Fort Knox and Fort Campbell here in the state, and that unfortunately that's not true, but there is still an increase 2019 over 2020. Now let's look at all deaths by drug type. You'll see that for 2020, fentanyl and methamphetamine have increased dramatically. However, look at the medium green graphs, and that shows peaking in 2016 and 2017, and year over year from 2019 up to 2020. The green graph showing benzodiazepines, that was a huge blip. So here, and this is probably the scariest slide here, because when this came out, when this research came out from the Kentucky Department of Public Health, it got particularly the attention of not only Pro Assurance, which is the second largest, well, actually, Pro Assurance is the third largest, but the second largest is SBMIC, Southern Volunteer Mutual Insurance Company, I consulted with, and their fear on this is that malpractice lawyers will key in on this slide to show that the unintentional overdose deaths will make physicians more liable to be sued. And the action by CMS now to limit chronic benzodiazepine prescriptions, and especially concurrent prescriptions of benzodiazepines and opioids, it is fortuitous, and it is we're not planning at all.
Excuse me.
Yes, question?
Not looking at this data, particularly the upper left-hand graph, the unintentional,
Yes.
is that related to street fentanyl or fentanyl products, carfentanil?
Okay. Let me go ahead and explain that in graph later on. Okay. But if we look at back one slide, they grouped all fentanyls together, but that is almost a 100% increase from 2019 to 2020 of fentanyl overdose. 95% of that is fentanyl that is not prescription based. So yes, that's a very dangerous trend. Fentanyl is at least 100 times more potent than heroin, and its street availability is increasing. The bad thing is it has to be brought in. There's no, the domestic creation of fentanyl is very low. Okay, domestic creation of methamphetamine is extremely high. Okay, so this is a slide showing by intention, and so I combined this by intention as well as all drugs, and you can see that in 2020, out of 1,965 overdose deaths, the unintentional aspect was easily 96, 97%. So even if it's being prescribed on a short-term basis, even if it's being prescribed appropriately, please put in your risk mitigation documentation. And those are words from Pro Assurance and from SBMIC. I did not get a comment from the individual yet. Those are three, by the way. Those are the three largest malpractice insurance companies here in the state. So since you know all the badness of it now, let's go ahead and look at the benzodiazepines themselves. Benzodiazepines were originally created in the 1940s and 50s, originally created as a muscle relaxant. People would get back strain and would get prescribed. The first one was diazepam, and they found that they all got happier. And they had less anxiety. So it became initially an anti-anxiety medication, but these are the 6 current appropriate uses for prescription of benzodiazepines. But one thing that I will emphasize are these are all short-term uses. And that's what CMS is trying to get our practice to change, and that is getting benzodiazepines on a short-term basis only. Now that will have a very profound effect for some practitioners. In the pain clinic, I can state that the concurrent prescription of benzodiazepines usually prescribed by primary care physicians as well as primary care nurse practitioners. And then the continuance of opioids was a huge red flag, both by the OIG here in Danny Cameron's office. Okay, he's the current Kentucky Attorney General, as well as the Kentucky Board of Medical Licensure. That is an automatic red flag. And the way that you providers get drawn in on that is on the reverse Casper, which is where law enforcement, the Kentucky Board of Medical Licensure, and the OIG of the Attorney General's office will go ahead and do a reverse Casper and see what you are prescribing. Here at the TJ Pain Clinic, we will send out letters to the prescribing provider who is prescribing benzodiazepines, and they have to sign that off saying that they are fully aware that the patient is enrolled in the TJ Pain Clinic, and it is in the patient's best interest to go ahead and taper down the benzodiazepines, or at least explain why they're going further with the chronic prescription of these benzodiazepines. Benzodiazepines, when they first came out, it was the cure-all for everything, very similar to what CBD was 2 years ago. So you know that CBD has been touted to cure everything from insomnia and impotence and unhappiness, depression, anxiety, and their advertising was consistent with that. So you can't set her free, but please make her feel less anxious. So I think this advertising was from the 1960s. And my favorite is when denial is the best alternative, encouraging the prescription of value of all things. So let's look at, now we are, 50 years later. I am getting old. Okay, so here's the number of deaths of benzodiazepines throughout the years. This only goes up through 2015. Remember, this peaked in 2017, and it's and then we have the 2020 numbers, and it's getting close. And 2021 numbers are beyond any previous peak. And those, again, these are the deaths from benzodiazepine. You can see that this graph is by male and female. So you asked about sourcing. Strictly from the benzodiazepines, okay? We know that almost 60% of them are from friends and relatives. I can't tell you how many times a patient would come in and we go ahead and do the urine drug test. Now, the urine drug test takes a little while. We usually get the results 72 hours, 96 hours later, because it's a test. It's a quantitative, not qualitative. It's a quantitative test. We actually don't want to know by numbers how much is positive, but we also want to see all the metabolites. because that tells us, hey, they didn't, they haven't taken it for 2 days, and all we have now are just metabolites. But 58%, they're not even prescribed. We look at the CASPA, and they're not even prescribed benzodiazepines. But 58% come from friends and relatives. 24% of benzodiazepine, the inappropriate sourcing comes off the street, and 20% comes from physicians and nurse practitioners. So the vast majority really is not under your control, but you are being measured for it.
Excuse me. Could you just repeat that last statement?
Sure.
It occurs to me that 80% of this problem has nothing to do with us.
Yes.
We carry the water for this?
Yes, so a study.
Or am I just missing? Just slow that down.
No, you're not missing anything. When HB-1 was created back in 2012, without KMA involvement, by the way, okay, the KMA was not asked to get involved with the creation of that bill. The KMA asked Attorney General at that time, where are these people getting all these appropriate, inappropriate scheduled medications? And 80% of those medications came from out of state. Okay, so these statistics are not new. So yes, you will be measured for it, despite your not being the cause of the problem. Okay, so what CMS 506 does is saying, hey, you've got control of that patient in the hospital. So we're going to measure, is that patient being discharged on the concurrent administration of an opioid or 2 types of opioids. Okay, so it's a little bit disjointed in terms of what CMS wants to see. But you understand that these patients are getting medications not through their regular providers.
But aren't their friends and family probably getting it from their regular provider and sharing part of it?
They can be, or again, they could be getting it off the street and then giving it to a friend or relative. Yes.
And how much of it off the street is coming from prescription?
I have not asked that question, and it would be very, very difficult to find the answer.
I guess that, because to me, it gets down to, is it being prescribed somewhere and then diverted? I think that may be the argument why we're being held accountable.
And Casper has helped. Now that, remember when HB-1 was created, we all had to use the Casper system. But we got garbage information because HB-1 did not force the pharmacies to enter the data. Okay, that was on the first revision. So with this being the sources of the benzodiazepines, let's look at how can benzodiazepines be explained as being the Black Menace? We now know, and this was evident, this was not evident when I was in med school, this was not evident when when I was in residency. But we have known in the past 10 years that with, and the reason I put Xanax up here is because it is extremely difficult to wean somebody off specifically Xanax. But we now know that with long-term usage of any of the benzodiazepines, and let's see, I don't know if we have a back connection. With long-term use of any of the benzodiazepines, yes, it has short-term problems, but then we have long-term problems even when it's not being abused. And you can go ahead and let's see, it would be right there. So long-term problems that that are most onerous are the original reason these medications were being prescribed in the first place. But we now know that once you prescribe these medications, they build up tolerance pretty quickly, like within 3 to 4 weeks, and definitely within 3 to 4 months. And so the patient may complain about that, so you increase the dosage, and now you're in a vicious cycle. Going back to the previous slide, you'll see even if a patient initially has, for example, the common that we see in the pain clinic is when a patient gets a short-term prescription for benzodiazepine because of the loss of family, and then 3 years later, they're still on that benzodiazepine. And they're stating, yes, I'm taking it, and I still can't get to sleep at night. And the reason is, as we know, benzodiazepines do increase the chloride channel influx, and that hyperpolarizes the postsynaptic GABA receptor, going back to med school, by the way. GABA acts as an inhibitor, and after tolerance has been achieved, definitely after 3 to 4 months, the fact that you're taking the benzodiazepine shifts that curve off to your right, as if that benzodiazepine wasn't even prescribed in the first place. The bad news about that is that then, if you keep it at the same level, the patient does exhibit some withdrawal symptoms, which makes it even worse when you're trying to wean the patient off. Here, we have a timeline of, and we've broken it down from 1 to 4 days, 5 to 19 days, and then months or years after the patient has been taken off the benzodiazepines, where we can see the patient can still have sleep disturbances, cognitive dysfunction, when the patient has been prescribed the benzodiazepine.
You see the inherent problem we're running into, which is we have our hospitalist physicians that are going to get leaned on. So we're going to come in on these benzodiazepines. You go to wean these guys off too quickly, what will happen is they'll go to withdrawal or to seize.
Great segue.
And that's the problem is, they're mandated trying to get these people out quickly. And then there'll be a break between the time they're discharged and the time they can get primary care. If they can, I'm having more and more difficulty with hospitals discharging patients with no follow-up. I know it says it on the record, but the patients gets no follow-up appointment. And all of a sudden they're within the withdrawal, and I see real problems here.
And there's a lot of problems here in Barron County because there is a paucity of mental health providers. And we can't be shuttling everybody over to Warren County because those providers are already overtaxed and overburdened, okay? So hopefully this discussion today will allow us to put some effort into recruiting mental health providers here in Barron County. Of course, as you alluded to, you can't stop this cold turkey. I've seen it happen before, and the patient gets admitted to the hospital, and that cost is astronomical compared to outpatient weaning. It's such a concern to NIH and CDC is that in your selection of slides, you have a government sanctioned, I hate to say that word, but a tapering schedule that they have put out. You can look at it and see whether you agree with it, and come to your own conclusion. I will say, if you want to use their schedule, please individualize your care, because everybody's different. Some people very highly motivated, and they can come off rather quickly over 6 weeks. Some people will need 6 years, and I'm not trying to exaggerate, I know that's a huge range, but everybody's different, and all the benzodiazepines are different. I've already alluded to the decreased titration of Xanax, very difficult. Other pain clinics, okay, IPS, Ciochetty in Bowling Green, and other places have had the same problem. And some places some clinics have refused to accept new patients who are on the concurrent prescription. CMS has been talking about this for about 5 years. So in this reduction in dosage schedule, the first reduction is 25%. I think that's very generous. But the patient needs to be counseled as to, hey, we need to be doing this, and this is why. Now, I told you that just taking away that medication is not going to be good enough, because if they truly have chronic anxiety, you need to put them on a chronic anxiolytic. Now, typically, chronic anxiolytics take 3 to 4, sometimes even 5 weeks for you to get up to a therapeutic dose. If a patient is not on a benzodiazepine and you need to put them on a chronic anxiolytic, this might be a good time to put them on a small dose of benzodiazepine, but still give them the risk mitigation counseling, but give them the option, hey, we want to start you on this medication. It's a scheduled medication. It's only going to be temporary until your chronic anxiolytic kicks in. So, using the biopsychosocial model that a lot of healthcare systems love to wrap their arms around, yes, it's a multidisciplinary approach. A few things that I want to highlight is of all things yoga, and that is therapeutic yoga, not this pretzel person kind of yoga. Okay, but therapeutic yoga. Therapeutic yoga, your therapeutic yoga classes should be ones where people with balance problems, with total joint replacements are enrolled. If you see people in there who can do a single leg, where you decrease, you sit down on the mat with only one leg, okay? That's probably not the type of therapeutic yoga class that you need to be sending your patients to. The other thing that I have found that helps tremendously is cognitive behavioral therapy, either on an individual basis or in group therapy. So those are the two biggest ways to reduce anxiety in these patients on a chronic benzodiazepine. Here in Kentucky, that suggestion to stop smoking at the same time you're trying to decrease the benzodiazepine probably won't fly for a high percentage of your smokers. So be very careful about that. Once you decrease them off benzodiazepine, then it might be a good idea to go ahead and talk about smoking cessation. So what CMS is looking for is a prescription of benzodiazepines on a short-term basis. And you tell that patient up front, that this is a scheduled medication. You give them the risk counseling session regarding that. And if those patients have been on benzodiazepine for a long time, then you need to go ahead and present a tapering plan. Some pain clinics across the U.S. will tell patients that if they are a smoker, you have 3 months to quit smoking. And they go ahead and encourage them and work with the primary care physician. If they're on a concurrent prescription of benzodiazepines and they get referred this patient who is on opioid therapy, they must be enrolled with a psychiatrist. Kentucky legislation currently has written that if you're on an opioid use disorder program, usually Suboxone, you must be under the care of a psychiatrist. You must be under the care of a psychiatrist if you are getting a benzodiazepine. Previous attorney generals have interpreted that, and they have expanded that to all opioids. So I'll put that out there. The current attorney general is not leaning that way. He tends to go ahead with the clinician's viewpoint. He puts a lot of credence in that. But just be careful. Attorney generals and governors change, and there's always that risk that they will be investigating you when there's that concurrent administration of both benzodiazepines and opioids. So let's go back to CMS 506. So let's understand that, yes, CMS will get involved with this health system, with this hospital, and with individual practitioners. Initially, it's just going to be take a look, hey, let's analyze what the rate is upon discharge. Now, it may morph into while you're in the hospital. But understand that they're looking for a concurrent prescription of opioids and benzodiazepines. Again, the schedule 2s and 3s on the opioids, of course, benzodiazepines are schedule 4. Or, and later on, we'll cover, what opioids, 2 different kinds of opioids. Usually that's a long-acting and a short-acting, which was all the rage back in 2015, 2012 through 2016. So any questions regarding CMS 506 as it's written now? Not yet. This is a segue to future CMEs, and this is looking at opioid usage. Now, I believe 2020, the U.S. had about 830 million people that resided here, and 92 million had at least one prescription for an opioid. A subset of that were the high opioid users, and this would be on a far more chronic basis. And then out of that, 2 million would be termed addicts. So you are beginning to understand that this is a multifactorial problem, multi-medication problem, and this is why this is all on the radar. In your packet, on the slides, this is the bibliography that I used for the vast majority of the slides. If it dealt with one single individual slide, that footnote was put on that individual slide. I used the PTSD reference there because we have found, especially through my military service, that, for example, like at the VA, people who are diagnosed with PTSD were automatically put on benzodiazepines. We now know that that is an inappropriate prescription, an inappropriate usage, especially not on the short term, on the long term management of PTSD. The VA has since reversed, in some centers, the utilization of benzodiazepines for this